Welcome to Unrestrained, the podcast series from CPI. Here you can enjoy conversations where professionals on all sides of crisis and behavior management relax and open up about themselves, their workplace, and their clients. You'll get the latest tips and trends from the best in the business, so tune in often to integrate their experiences with your own. Hello and welcome to Unrestrained, the CPI podcast series. This is your host, Terry Baton. Today I have the privilege of doing a video podcast with Mr. James Gulbranson and Paul Ruegemer of St. Cloud Hospital. That is part of the CentraCare Health system in Minnesota. It is a nonprofit health system that includes 6 hospitals, 7 elder care facilities, 18 clinics, and numerous outpatient and inpatient services. Hello and welcome, James and Paul.
Thank you.
Let me tell you a little bit about our guests. James Gulbranson is a safety and security specialist for CentraCare Health and has worked in the security field for 14 years. He is also a licensed Minnesota police officer with 5 years' experience in law enforcement. He is a taser, baton, and handcuffing instructor who has trained both police and security personnel. James has been certified in CPI's Nonviolent Crisis Intervention since 2011 and our Prepare training program since 2014, and he has taught over 1,500 hours of the training programs to over 3,500 healthcare professionals at CentraCare. He is married and has 3 boys, ages 5, 8, and 10. In his free time, James likes to golf and competes on a men's roller derby team. Paul Ruegemer has been a safety and security officer for CentraCare Health for 10 years and has worked for the organization for 12 years. He is a taser, baton, handcuffing, and use of force instructor who has trained both police and security personnel. Paul is certified in CPI's Nonviolent Crisis Intervention and Prepare training programs and has taught over 2,300 hours of nonviolent crisis intervention in the last 4 years and over 100 hours of Prepare training in the last year. Paul has trained over 5,000 healthcare professionals at CentraCare. Paul has a wife and 2 children that are 1 and 3 years old. And in his free time, Paul likes to hunt and fish and spend time in his cabin in Tower, Minnesota. James and Paul gave a presentation titled Practice-Based Evidence at CPI's Instructor Conference in New Orleans last July, detailing the hospital's implementation of CPI training and the positive outcomes it has helped to produce at CentraCare Health. We are fortunate that they are willing to give that presentation for us again today, so our certified instructors and other interested people around the world can enjoy and learn from it. If you're ready, then James and Paul, please begin.
Thank you. So we'll go over a quick overview of some of the topics we're going to cover today that we covered at the conference. First thing we're going to kind of talk about is a little bit more about CentraCare Health entity that we have, the different hospitals, the different clinics, like we're alluded to, and some of the different staffing issues we have at those locations. We're going to talk about the history of CPI, both the NCI and PTP program, and training that we've had at CentraCare Health. Again, talking about the successes we've had there and how we've used both NCI and PTP to train our staff and make them better prepared to handle these kind of situations. We'll show some graph examples of some positive outcomes we've seen over time through using this training. Again, we'll touch on some reductions in aggressive, high-level aggressive incidents. We'll talk about staff being better prepared and feeling safer at work, which is really important. And then we'll also spend some time talking about, in relation to the crisis development model, how we use that model to try to develop more strategies and more tools for our staff to better prepare them to deal with aggressive, escalating behaviors as they do occur. So to start off, we'll kind of talk briefly about our CentraCare Health. Our main campus is in St. Cloud Hospital, Minnesota. We have a predominant amount of our staff, security staff at that location. We are staffed with security at a few other of our off-site locations as well. Again, like Terry mentioned, we have our primary campuses at St. Cloud. We also have 5 critical access hospitals throughout central Minnesota. We have a number of clinics. We have a number of outpatient service departments as well. Some of the other areas and some of the staff we train are everything from social workers to home care staff to therapists to daycare aides at some of our locations. So we have a wide variety of staff that we train, both inpatient and outpatient style staff that we have at our locations. We also have nursing homes, long-term care, assisted living facilities, and training staff there, obviously that's a little bit different environment. They're not dealing with some of the same circumstances that an inpatient hospital staff would deal with, or a mental health staff member or an ER staff member would deal with. So we really like the NCI program and the PTP program, especially because it's so versatile and it can work in a variety of settings. It works for young, it works for old, it works for any of our inpatient and outpatient facilities. So it's a good program, and it does allow us that ability to tailor the content we need to have to the staff's most pressing needs, and that's one of the definite benefits we've seen using this program. So we started, NCI program started, a couple of our ER staff members wanted some extra training for their staff. They brought the NCI program into our facility, and it was initially just a training for ER staff, mental health staff, and security staff. That was the only assigned staff that would go through the program, and for about 2 years it continued in that manner. Eventually, with the observation that we had an increased level of aggressive incidents, increased level of people being more difficult, challenging, non-productive behaviors from both patients and visitors, it was determined that we would want to provide a little extra training for all staff in our facility. And in 2012, decision was made to move forward with training NCI program to all of our patient care staff in our facility. Talk about that for a minute.
Sure. So when we rolled it out in 2012, we did a 2-year requirement to roll that out. So all the staff members had 2 years to get through the program. We had roughly 3,500 identified staff members to go through the program at that point. And so we were offering classes day, evenings, and weekends to get this done. As we rolled through, we've seen a lot of very good changes at our campus, at the St. Cloud Hospital campus, and we'll show some graphs of that as we work through the presentation, showing those good changes throughout. After we identified and we got through all the staff members at our St. Cloud Hospital location, we then rolled out NCI to all of our 5 critical access hospitals and all the other off-site type of locations, offering them as an option, and then they slowly have been coming on board, mandating it for all of their patient care staff as well. Additionally, that we added, as James said, the PTP program, we added that in 2014 for our non-clinician kind of staff, for as we identify non-patient care, maybe staff members, business office, HR type of staff to be able to come to as well, as they were requesting some sort of additional training as to what to do with somebody who is becoming aggressive or violent at that point as well.
And that was definitely a learning curve in terms of identifying the appropriate staff to have the appropriate training. And when we look to provide some extra training, again for, Paul talked about groundskeeping staff, maintenance staff, business office staff, other staff that maybe even have some patient contact, nutrition services, housekeeping staff, what training best fit their needs. And we really liked that PTP program for a couple reasons. Granted, it was a little bit shorter, obviously for budgetary reasons that can be an advantage, but it was aligned with the NCI program. The verbiage was very similar. The crisis development model was still in place there, so that we found that everyone was having the same verbiage taught to them. Everyone was understanding that anxiety stage. Everyone was understanding the verbal stage, and then at that physical stage of how to best respond. So it made sure everyone on campus, not just our patient care staff, were kind of up to that right level of training, and everyone was using the same terminology. That's definitely a big change we saw. A good example of this in security, especially before we started this training, we'd get a call from staff members saying, I've got a guy up here who's really angry. Well, that could mean a lot of things. When we talk about this training for staff, we help them to identify, is the person in your lobby, arms crossed, pacing around? That guy could be angry, yeah. Is he standing at the desk yelling and screaming at you at that defensive stage? Yeah, that guy's angry as well. Is he throwing a chair at you? Is that guy angry? Yeah, he's angry as well. But their behavior is going to dictate our response. We really worked with staff to identify what behavior are we seeing, and really keying that into what's our best possible staff response. And that goes for our patient care staff, as well as, again, non-patient care staff that do come in contact with a lot of our clients, our visitors, and patients as well. So we really like the integration of using the PTP and the NCI program for assigned staff. They gave us a lot of flexibility in our training as well.
First thing I'll talk about here is one of our graphs that we're going to pull up. It's our percentage of initial NCI staff members trained. And so as it works through, you guys can kind of see we started off with July of 2013, and that's when we had the big push to start. We started fiscal year July 2013, end of 2012 for our fiscal year. We got everybody trained up. As you guys see, when we get to about that May of 2013 or so, 14 fiscal year, towards the end of that fiscal year, we had roughly 90-ish% staff members trained. That's kind of a key number because that's when we had almost all of our staff members through, and you'll see that as we work through the rest of our graphs, the changes we've seen at our facility as well. We did have when we kind of look at our graph that's pulled up, you'll see a decline that occurs. What ends up happening there is we identified multiple other staff members that need to come to NCI or were identified as coming to NCI, and so that kind of reflects that change of bringing more people into that, and as we slowly got everybody trained in our NCI program for our entire campus.
Again, at that drop-off point where it looks like there's a drop-off, as we're seeing more and more successes, you can see we ramped up our training pretty considerably from just the handful of ER, mental health, and security staff in our facility up through the identified 3,500 or so staff that needed to be trained. As we were having more staff trained, as there was better word of mouth, as we were seeing even good results in the early stages, more areas, more departments, more staff wanted to be brought in on this and wanted to be able to go to this training. So again, we had a little bit more hiring and we had a lot more staff directed that should be going to this training. So, and you can see as the graph goes forward, we were trying to get close to that 100% mark of all identified staff, and generally at this point we're floating pretty close to 100%. As new staff come on board, we train them within the first 3 months of hire, but it usually happens even quicker than that. So we try to get everyone on board. It's kind of part of the new staff process, as well as getting them signed up for their NCI class. It's really become a kind of a cultural shift in our organization that is really important. A part of the training they receive, anywhere in our facility.
All right, our next graph that we have pulled up on your screen will be our work days lost and our work days due to aggressive incidents. So as far as days modified and days being off of work, as you guys can see in fiscal year 2012, we were quite high with our days modified, which means a staff member is unable to perform their normal duties and they are assigned other tasks throughout our hospital, generally obviously not doing patient care, and then our days lost, obviously them being off. As you've seen from our previous graph of NCI percentage of staff trained, this is a direct correlation as we get to fiscal year 2014 of that dropping off substantially for days modified and days lost, coinciding with our NCI of our staff members being trained. There's no other variables that were factored into as far as that. There's nothing else that really changed at CentraCare other than NCI being rolled out. And so we've seen that dramatic decrease in days modified, days lost by our staff members, which obviously really pertains to our NCI program, really gives us a good snapshot at how this has helped our hospital and our staff members at this point.
And I think that 2 years seems like a long time, but when you've got that large amount of staff that you identify to go through, thousands of staff, I think having it a shorter time period like that was important because you got everyone quickly up to a certain level of training and experience and readiness. And again, as we can see here, and we'll see going forward in some of our other data examples, some really meaningful changes occurred that really can be directly related to the training staff received. Again, talking about, I'll kind of break down a little bit how our classes go as well. We limit our classes to, if it's one instructor, we have 12 staff in the class. It'd be capped at 12. If we have 2 instructors available to teach, we do a class of up to 24. And then if we do have 3 instructors, it would be 32. But generally, we kind of focus on 2 instructors and that 20 to 24 staff member range. And that does give us that good amount of time. It gives us 8 hours to work with a small group of staff, really focus in on their needs, their concerns, and they get some one-on-one time that really helps them ask the questions they maybe need to ask and gives us time to answer those questions in a meaningful way, again, and using the CPI model as kind of our guide through that. So beneficial, and again, those small groups sessions really were beneficial, and again, we'll see that going forward here.
Absolutely. Our next slide we have is our total workers' compensation expenses due to aggressive incidents. So when we started kind of tracking these, we worked through, and we started it again at fiscal year 2012, prior to us starting the NCI program rollout. As you see, as we got to fiscal year 2014, you see the significant drop-off on the graph of those amount of workers' compensation incidents. And so again, just kind of getting back to staff members getting done through NCI and this change that we're seeing of less injuries, less problems with staff members needing to be off work, less expense to our organization as well as far as for workers' compensation. And so again, that kind of really gets home the fact of NCI being done has really had a big shift at our facility, and we'll talk through that as we work through. James will talk about our sitter hours here.
So I added this information as well as important, especially when you're looking at, and again, we had a great amount of support from our leadership up through the level of president and vice presidents at our facility that identified this idea of violence in healthcare and in the workplace, but in healthcare in general. Very behind helping staff, very behind providing services, and what we needed there in terms of basically staffing hours and the financial end of it. So we had a lot of good backing from our leadership early on. And again, we mandated this program for staff well before it was a statewide mandate to have all staff trained. So I think we were really ahead of the curve, and really have to thank the leadership and we have in our organization for providing that extra resource and providing that encouragement to do these programs. In looking at trying to roll a program like this out for a larger entity like a hospital, trying to find where's money, where does this save us money, where does this help us, where does this not only provide good care, but we also want to look at the financial end of it. One thing that kind of came out of this and looking at some of the documentation here is our sitter hours. Those are where staff are assigned to sit with a patient. Some could be for medical reasons like fall risks or pulling out tubes, and some can be for people who are suicidal, on a hold, et cetera, in our facility. And that takes us, a certain staff member's got to be in the room 24/7 with this person. And looking at, going from 2012 and going forward, you see the amount of time that we're assigning sitters to staff and to patients has steadily decreased. Now again, our patients that are fall risks, haven't changed a lot there, but the amount of sitter hours we used, I think partially has gone down because of extra staff training and really thinking about what does this person need? Does someone need to be on a one-to-one sitter? Can we just provide some extra rounding with staffing? Can we provide our staff better training so that they can deal with these issues as they occur with their patients and maybe not require that sitter? Because in the past, a lot of staff would see a patient as being potentially difficult and want to have that sitter just to kind of take the load off and not having to deal with them so frequently and have a staff in there at all times. But maybe that was not always the best choice. So by getting all staff some extra training, they felt a little more confident to maybe handle some of these situations without tying up as many resources. So again, looking at some of the documentation here, you can see over time the amount of sitter hours we utilized did decrease as well. So that's one thing to look at in terms of cost savings as well as certainly good.
Our next graph we have, we're showing our violent incidents. We do have a reporting system for violent incidents, even if somebody isn't injured or hurt. We've had this reporting system. And so our next graphs, we break them down into different levels, 1 through 5, which is done by our occupational health department. So they identify, they meet with the staff member and classify it in a number as far as what type of event had occurred. So when we start on our graph here up on the top left, it basically is talking about near miss. It's talking about lower level type of situations. As you see, as our NCI got trained, those numbers went up. A lot of our lower level incidents, which are the top two and working their way down, are the lower level incidents, and those went up. And we had some questions as to why we were getting more of these happening, and it's not a fact we had more of them. One of the things we really push in our NCI programs or PTP programs on any of our educational programs is making sure we're reporting what's happening. Because if we don't report what's happening, we're not likely to get the resources to help solve this problem of what's happening. So we had a very sharp increase in reporting. It's not that there was any more incidents occurring. It was a fact of staff were now feeling enabled and empowered to report what they had going on in their areas. And as we look at those graphs, we work our way down towards the level 4, level 5, where we're talking about staff member injuries, staff members off work. It coincides directly with our other graphs of those went down. We had a higher level, and now they're trending down, and so that goes to the fact of higher reporting, but yet we're reducing the higher level incidents, and that was the big payoff behind NCI PTP, is so that we could get the staff trained, get them reporting, so we know what's going on, so we know where we need to add things or do we need to add more resources. And so that was an important one as well as we worked through the program.
Looking at this as well, the higher level of increased level of staff dealing with people that were more verbal. Dealing with people more at that anxiety stage or defensive stage, that's where we want people intervening. And that's the big thing we push for is we should be intervening at that stage before it gets to that level where there's a physical intervention needed or assault occurring. So we did see those numbers increase in terms of staff reporting dealing with people who were more agitated, who were yelling or swearing or shouting, because we empower the staff to deal with those behaviors at lower stages, and oftentimes we could stop it at that point before it did escalate any further. So that's another reason we saw that big increase in lower level numbers, and we see a big increase in our security calls as well that we noted over time, and we'll talk about that in a little bit as well. So we'll kind of now look through some of the changes we made as a result of our NCI training, as a result of our PTP training for staff, and how it kind of correlates. And the model we really used was that crisis development model. How do we empower staff at each of those stages when they're dealing with behaviors that are occurring? How do we best empower them to manage those behaviors, deal with them, and have the resources they need? So in looking at the first level here, that first stage of the crisis model being anxiety, how do we best intervene when people are at that level? This stage was probably one that we maybe had the most trouble selling to staff, and I know for Paul and myself, when we went through the training, this was a stage we kind of went through quickly as well. Didn't really think it was as applicable. Am I supposed to just walk up to somebody who looks angry or upset and ask them what's going on, ask them what we can do? It seems counterintuitive, it doesn't seem natural. But as we train through this, as we put these methods into practice, we can see how that can be really effective and can help somebody and can stop a situation from escalating. You've got someone in a lobby who's upset about a wait time and they don't know how long it's going to be. If staff doesn't talk to them, they could eventually escalate to the point where they're being verbal or more. Just telling staff, even approaching someone who looks upset and telling them a reasonable expectation of a time of a wait. This is how long the wait time is, this is when we're going to get you in, this is what's going on. Keeping them updated can be a form of this, relieving that anxiety that comes at this stage. So really getting staff just to appreciate when they identify something that's out of place, in a patient, in a visitor, something that's out of the normal behavior that they normally see, trying to intervene, trying to take that time to intervene at that point before it could potentially escalate. Another big push we added in as a result of this training for staff was calling for extra help. A big thought in nursing, and we found from a lot of staff that had been there for 10, 15, 20 years, was the expectation, and even on themselves, was they deal with the situation on their own until it's completely beyond the point where they can handle it anymore, usually at that physical stage. And we really worked with them and talked with staff, identifying that you can call for staff, you can call for assistance earlier, and oftentimes you should be calling for some extra help. And that extra help could simply be another coworker. It doesn't necessarily have to be a security or law enforcement or any kind of special team you have at your location. If something doesn't feel right, if you're concerned about a behavior, to trust that instinct, call some extra help in. Call a coworker to stand by while you talk to a patient. Go in with 2 staff members if something doesn't feel right. Making sure you take that little step, because oftentimes after an incident, maybe a higher level incident, we talked to staff and they identified early on that something didn't feel right. They were feeling uncomfortable in a situation, but they didn't take any steps there. So really empowering staff to know if something doesn't feel right, call another staff member, call security. We'll come up, we'll stand by, we'll assist you with any situation there. Even, again, at these lower level stages that maybe seem like we should just avoid the problem there.
And when we're talking about this, this anxiety, this nonverbal behavior, for all of our instructors obviously out there, you know what anxiety is. So again, that nonverbal type of behavior, and the big thing, to really think about when we're instructing these programs is trying to bring in examples from the real world and bring in examples obviously from work as well. When we and James started teaching this program, the primary staff teaching this were mental health nurses and as well as ER nurses. And the problem we kind of noticed as we were rolling this program out was all their examples are from the ER, from the mental health. And when we have an oncology, medical, ICU nurse, it's kind of hard for them to relate to that when we're talking about ER, mental health. So being able to bring in different examples. An example I like to utilize at this anxiety nonverbal stage, we're talking about nonverbal, is thinking about what you would expect if you were in the situation or if you were in their shoes. The example I give is if you're out to eat at a restaurant and the glass of whatever you're drinking is empty. Well, what do you do first to get the message to the waiter or waitstaff that you need a refill? What are you going to do at that point? Well, oftentimes, you're moving your glass to the edge of the table, you're staring at them, you're slurping your straw, you're rattling the ice, you're trying to send them a nonverbal message. And it's the same thing as we identify with our patients. Our patients are doing the same thing. They're coming into our lobbies, tapping their feet, they're looking at their watch. It's the same thing. And so if we go up and acknowledge it, just like at that drink class example, if that waiter or waitstaff comes up and acknowledges you and refills your drink, there's nothing more for us to do at that point or for them to do. And so think about that in relation to us at work as well of what do you want to have somebody doing when you come in here and taking that step to do that, of telling people how long it's going to be, how long the wait is, etc. Same example with that drink glass. If our needs aren't met, and now we're sitting there and they've walked by 5 or 6 times not refilling that drink that's on the side of the table. Now we're going to do something different, and now we're going to bump up behavior. And so we want to try to prevent is patients, clients, coworkers, etc. from bumping behavior because we're not getting that nonverbal message. We don't want them getting that defensive verbal type of a stage because we didn't get it. And so it's picking up on behavior, and that's an important one as well. We talk a little bit about that defensive verbal stage, and when we kind of talk about this with our staff members, it's being able to recognize what do you need for a team. Because obviously that verbal stage, as we all know, can look a lot different depending on the person. And so again, identifying what do you need for that team, what do you need to call at this point. Oftentimes this is where for our verbal situations we're telling our staff to call our B.E.R.T team, which is our Behavioral Escalation Response team. And me and James are going to talk quite a bit more in depth on our B.E.R.T team a little bit later on. But again, when we're calling that B.E.R.T call, this is kind of for that verbal patient. This team has 10 minutes to get to that location. It only consists of 3 people. It consists of a mental health staff member, a nurse generally, one of our security officers, and then a urology tech / orderly staff member. And again, they have 10 minutes to get there. They meet with the nurse from that unit, from that area. They meet with them, kind of consult with them, come up with a plan, possibly meet with the patient. They might bring in other resources like pharmacy, psychiatry, etc. But this team is there as kind of a resource as a consult to help our staff members on the rest of the units and really to model and show what this can look like. And we'll talk more about B.E.R.T numbers later on. But again, calling early, intervening early is our big push, as James alluded to earlier. Oftentimes what used to happen is staff would wait until that person's throwing a chair or they're punching somebody, and they'd wait till that last minute to call anybody, and we're really encouraging people to call early, intervene early. Another big one from our slide we've pulled up, calling security early, having our security officers intervene early. Again, with all of our staff members that are St. Clair Hospital campus, that are patient care staff members, trained in NCI, there's never anybody showing up that doesn't know how to deal with these incidents that are occurring. And so we have kind of that advantage of having everybody trained. We know that whoever we're calling, they're going to know what's going on, and they're going to know how to best intervene at that point as well. And so that's quite a bit to our advantage as well.
Another change we made in our program, and over time with any program, it can be repetitive if you have staff going and refreshing every year. We found that if we had any complaints from the program, it was the refresher program was kind of the same every year, and staff wanted to see something different. We went to one of the CPI conferences and did a breakout session about refreshers, and found out there's a wide variety of NCI refreshers that are available to be used to meet that refresher need. And so going forward, we're actually going to be rotating. We do our key point refresher. This last term here, we've been doing the setting limits refresher for all of our staff going through. And there's a lot of other options out there, and we're going to kind of rotate back between the key point, and this year is going to be setting limits, and then it'll be back to the key point, and after that we'll choose another refresher option. One, to keep staff engaged, and 2, it gives us the ability over time to see, what issue does staff most need extra help on or are requesting extra assistance on. We chose the setting limits refresher for this term of training because we felt it could maybe best meet the needs of a widest majority of our staff. A lot of staff think of that setting limits as just when someone has difficult or challenging behavior, how do we manage that? And that's certainly a big part of it. But part of that too is what kind of limits, what kind of boundaries do we set before issues even occur? How do we manage the situation? How do we state our guidelines maybe before a situation even needs to have a limit set there? So we have a lot of staff going through this program now, and we've seen some good results coming from it. So a good tip we had there was to kind of alternate our refresher programs to keep it fresh, keep it interesting for our staff. Going back to the B.E.R.T call, like Paula talked about, another reason we wanted to add that program in, this B.E.R.T team in, is we saw a lot of people calling for our high-level team, which we'll talk about here shortly, at this stage. When someone is upset, yelling or shouting or swearing, oftentimes in the past, staff would call for our large response team. And if you've got someone that's upset or angry and you run 15 people into their room, that does not calm the situation down. It never makes the situation better. We found that oftentimes our staff response at this stage was escalating the behavior and making it worse. And that's a big push we have in our training is for staff. One of the first things we tell them is we want to give you some tools to help de-escalate a situation, certainly, but we don't want you as a staff member to go in a situation and by what you're doing, you actually make the situation worse. And we saw that we were doing that quite a bit. We were calling this big response team in a situation that would maybe just need 1 or 2 trained staff members to come in and try to assess and manage. So this is probably one of the bigger changes we definitely made as a result of some of our training of staff in this program.
Absolutely. Our next one we have is talking about that acting out person. And so, again, when we do get to the extent of that larger physical type of an incident, talking with our staff members and talking about what's the expected response here. A big thing we pushed was for staff not to intervene alone, and we started looking at a lot of our injuries occurring to our staff members. A lot of them are occurring when staff members are trying to intervene alone or not calling for help. And so we're really pushing on intervening as a team, utilizing a team, getting out of that room, and getting that team involved, which all of us know for our NCI and for our PTP is getting that team involved and then going in and readdressing. Utilizing those other team members. We have our larger, as James was kind of alluding to as well, our behavioral response team, our security alert behavioral response team as we call it, which is paged overhead at our campus at St. Cloud, and that does have multiple people that are responsible for responding, but it does initiate, as James said, roughly 15 people coming to that location, and that group is bringing restraints and a lot of people because we are assuming that we have a physically acting out person. And so by us identifying and working through this CPI model, it's being able to call appropriately, like James was saying, not having that security alert being called for somebody that's just yelling and screaming. Calling the appropriate team so we get that appropriate response is important in making sure that we're utilizing our teams correctly.
Again, at this stage, that Paul talked about this team and our security alert team, it's 15 people. It's all available security staff on. That could be 4 to 6 staff members. It's going to be a couple of urology or orderlies staff. It's going to be staff from mental health, ER, available staff in that area, administrative nursing supervisor. A wide variety of staff are responding from all over our building. Certainly we want to limit the right staff responses as well, but another issue with those kind of calls are it's very disruptive to the hospital environment. You've got staff coming from the ER, mental health, security could be spread around all over campus, same with some of the other staff, running through our facility to a location. And what we really want to stress to staff is if you need that team, be comfortable calling it and knowing that there's a bunch of people running to come help you, and we should be there very quickly. But on the other side of that, we don't want to initiate this team that is very disruptive. Again, running through our facility, staff are running from all different areas if we don't need it. We don't want to cause that extra disruption. And that's where the advantage of that B.E.R.T comes into play is staff that are responding are walking. We're getting to the room as quickly as we can, but we're not causing as big of a disruption there. Other part about this that we worked on in looking at what training we need, because as we're getting staff trained in NCI, now we found that we had all of our staff on campus trained to a certain level, which was very good. And we had staff from ER, mental health, kind of deal with those situations a little more often. We maybe wanted to provide a little extra training for them. Paul and I, we identified an extra need that we had there. We found that we work with the mental health staff quite a bit in security. We work together quite a bit. We're on a lot of calls together. But we kind of determined we don't train together. We don't have any trainings together. We don't do any simulations or anything together. So we set up a simulation training lab for our security staff and mental health staff where we would do a scenario. Paul or I would be the actor, and the other person would facilitate it. And we do a group of 2 security staff and 2 mental health staff responding to a call. And we recorded it, so we were able to have staff work on a specific kind of behavior, specific kind of issue, and watch it from beginning to end with them and sit down and actually do an immediate debrief. And that kind of helped not only us learn from that, but it really helped our staffs get a little more comfortable with each other, working with each other, of calling each other, and doing some training together. So if we are on a real call, we kind of know what to expect from each other. So we added that in, and we did add a restraint element to that. Again, we added some extra training in for our mental health staff on actually putting restraints on, because again, obviously our goal is to avoid as many restraints as we can, but some situations someone does need to be restrained. We still want to do that as safely as we can using kind of those best practices. So we did some extra trainings where we have Paul act as our person that's acting out, and the staff member go into scenario, and they practice putting the restraints on in a more dynamic environment. certainly not full speed, but certainly a little bit more than just walking through it as well. And Paul kind of took the lead in doing that training and some other training with their ER staff as it relates to restraint. Do you want to talk about that
We
briefly?
added, at our facility, again, we try to avoid restraints as much as we can. Initially, when we started doing our NCI program, rolled out to all of our patients' care staff, we also did a short part on restraints, talking about the restraints, obviously utilized as a last resort, but also getting all of them up to speed too, because a lot of them maybe hadn't had time to actually get a restraint in their hand and look at them. And the big thing with restraints, and when we talk about restraints, is if we don't apply them correctly, we obviously have a higher risk of an adverse effect with that patient. And so we want to make sure staff are getting them on right. One of the things we've added recently in our facilities is we've added restraint chairs. We have restraint chairs in our mental health and in our ER now. And so we're doing training on that to make sure all of our staff are trained well, again, as a last resort. But if we do end up getting that, and if we have this equipment, we need to make sure that we are training our participants, our people, the best we can. And so we run sim labs with them as well, making sure they know how to put them on. Again, we put them through a short scenario, get them talking, mainly to me at this point, talking to me about what is going on, trying to de-escalate me, go through the crisis development model, and then ultimately, it doesn't matter what they're going to say, I'm going to get to the point of restraints, but we want to make sure they're doing it as a last resort, that they're not coming in too soon and doing it. And if they do, then we talk about it and we work through it. And so we tape it, we make sure that we can go back and we can look at, what can we do differently here, how's your positioning in the room, what was your body language sending to me, and did we maybe do this too soon, or should we maybe done it sooner? And so thinking about that as well. And so we've really worked through our different restraint trainings and our different acting out behavior as well, because there's a wide range of responses, because again, looking at what that person's really doing.
And we have the advantage, we have a simulation lab at our St. Cloud Hospital location. A number of rooms are set up just like patient rooms, but they have cameras in them that we can practice any of our scenarios we'd like to in there. And we even use some of those videos for our NCI training to watch afterward, like Paul mentioned. Look at a scenario. Again, it's not meant to pick apart what was done wrong, but it is, how did staff respond to this person? How did they approach? Did they all surround the person right away? What was the staff's body language? And we use that to kind of touch on all the areas of the NCI program, of how did they respond, how did the patient respond, what did the staff do well, what can we learn from that? What is their positioning in the room? Even those nonverbal things are nice to be able to look at right after the fact, either for the staff involved in the simulation or for all of our staff afterward, to really get some good takeaways and really think about how do I respond to a patient in a crisis? How do I enter a room even? What is my body language sending? And again, we want to touch on and kind of reiterate those points, because it is important that message we are sending non-verbally as well. And then the last part of the crisis development we talk about is that tension reduction stage. And that's after the incident is over. Again, talking about what do we learn from that? That's another thing we like to stress in our programs are, after an incident occurs, beyond the debriefing process is also for our staff is, what are we taking away? What do we learn? What can we do better next time? And how can we use this information to help us and everyone else in our facility? One thing that we started is a security rounding trial, and then a security rounding group that we did. And with that group is we found that some staff felt that maybe they didn't see security a lot in their area. They'd feel more comfortable if security was checking on them when they had a difficult patient or a challenging patient. And we had a subgroup meet to talk about, how can we best deal with this situation. So in security, we did a trial on our neuro unit, who asked to volunteer there. And what we did there is we had a staff member in security every 5 hours would round to their unit specifically and meet with the nursing staff that had any kind of difficult patients. And that could be anyone from a person with a TBI or any other kind of difficult, challenging behaviors. So we had security rounding this unit. Again, one person would touch in at least every 5 hours with staff, meet with the charge nurse, get any updates about patient changes, plans for patients to move to other units, discharges, etc. And we had that little extra stop on this unit. And during that trial, we had some interesting things occur after that trial, some interesting information we got after the fact. Because we had staff fill out evaluations every day beforehand and then afterward of what their perception was. And the number that's really shocking is we found 92% of staff felt more safe on their unit with this little change in us in security, stopping once every 5 hours just to touch base and talk with them. The other thing that was probably most surprising for me after this trial ended, we did it for 3 months. When it was over, they talked to staff about 3 months later, and they still thought we were up there doing a trial. They still felt we were checking in more. I think part of that was staff felt more comfortable. When they'd see security walk by, they'd feel more empowered to flag us down, tell us if there was a concern. made us more aware of security, and it made that connection with the staff a little bit more. I think that was probably the biggest gain we had from that we made was, identified a unit that was having struggles, which was the neuro unit, and how do we provide them better support? Again, this was one thing we could do after an incident to say, how can we best support the staff? How can we best provide them service within the capabilities we have? And by stopping and checking with them, passing along in our office, we would pass along any challenging patient behaviors we saw on their unit for the next staff to go and follow up on. So the nursing staff felt like us in security were more well prepared and more versed in the challenges they were having specifically. They were quicker to call us for issues, and we did see a decrease in incidents occur during that trial, certainly. Another thing Paul and I became a part of the Aggressive Incident Prevention Committee after we started teaching. That was a committee that was put in place to really address these kind of behaviors that we're seeing, not just in the ER or mental health, but in our whole facility, in all of our medical units. So as part of that committee, we review incidents that occur. We have some of these subgroups to deal with specific unit issues or general issues throughout our organization. A couple of good things that we've started to do through this aggressive prevention committee is start to branch these ideas out to our other critical access hospitals who maybe have less resources than we have. They don't have security, most of them. They don't have mental health staff or units there. So how do we best help them? And a part of this committee as well is we put on a training for other sites a couple times a year. They can come together. We can share some of our successes. We can share some of our tools we've utilized to help not only our main campus, but kind of get everyone else, our other hospitals, on board with some of the best practices and some more tools that they can utilize. You want to talk about unique treatment there?
The other thing we kind of implemented, and this was going on even prior to us teaching, they were working towards this. This started on our mental health unit. We started with a unique treatment plan because one thing we were finding is after these incidents occurred, we dealt with it, we've moved on. Sometimes when we deal with people, not even on a frequent basis, but over and over again as they come into our facilities, it's like we're starting over every time. We don't have a plan in place. We don't know what the plan is when they come back in. And so after a aggressive, violent incident, we generally will trigger some sort of unique treatment plan. Either our case managers, our mental health case managers will trigger this on any of our floors or on our mental health unit or ER, or even our social workers will trigger this. And they sit down with the patient and talk about what are we going to do to prevent this from happening again? What can we do as an organization to help you so this doesn't happen again? And then also on top of that, we kind of talk about our expectations as well. Going forward, what do we expect of you as the patient, as this goes forward, as an acceptable behavior that maybe happens. If it happens, this is what we're going to do, this is our response. And so again, really having that buy-in with the patient of being a part of that and having our frontline staff that are dealing with the patient, having a plan in place so that they know what do I do next time, what works best with this person, what's the best practices, what are we allowed to do with this person, or what does work with this person is important as well. And so really thinking about that. The other thing we have on here is that follow-up from the mental health RN or case manager after B.E.R.T. So after any of our B.E.R.Ts occur, our behavioral escalation response team, roughly 2 hours, hour depending on the patient later, one of our staff members from our mental health unit or case management staff will call up to the floor that it occurred, talk to the RN involved, see if there's been any changes, see if they need anything. Offering that support afterwards is important as well. We've gotten a lot of positive feedback from that as well of they're calling back, we care, we're definitely taking an initiative of trying to prevent this behavior from going forward. And sometimes being able to identify if we maybe need to do some things different or do we maybe need to do some things better. And so having that follow-up is important as well after that B.E.R.T call occurs. So it isn't everybody shows up, then everybody leaves, and now they're by themselves either. So they have that support, and that's important.
That was a good change made there, is that we are providing that support after incident as well. We're not just responding to the call to help, which is certainly vital and important, but staff are feeling that they're being supported even after the incident, even with a phone call a couple hours later. Because if there are concerns brought up then, we can try to reinitiate the team, we can try to come up with some more options for that person. And again, as well for security, when we have a B.E.R.T called, we put that up on our pass-along boards so other staff know that this patient, what occurred with the patient, what the plan is going forward, so that if they have to respond up there, again, they're not starting from scratch either. And going back to the security rounding idea, again, adding those things in after the fact of how we can support staff. After our trial for that security rounding, as you can imagine, a lot of the other units wanted to get on board and wanted to have that trial or wanted us to come to their unit and do that. And looking at the time restraints that would come from that, we found that maybe would be something we wouldn't be able to do in our security department. But what that did is it led us to getting a printout every day because we don't have access to the computer records there. We get a printout every day of any aggressive patients that have been either had aggressive incidents occur or score high on our BROSET tool or are identified by staff as maybe being difficult or challenging. We get that printout every day of the patients in the hospital that meet those criteria so that our staff can look at that and we can do extra rounding on those areas and those units that are most in need. So it helped us get that communication tool from staff on the floors who, again, oftentimes assumed we had the same access to the information they did, and we really didn't. We didn't know something unless they told us. And again, that goes right back into what we've been talking about all along for staff is notifying us, telling us when there's an issue, getting help right away, whether that being calling us in security with a heads up, or whether that be calling a coworker, calling our B.E.R.T or our emergency response team, utilizing the different tools we have in place and using those to make a safer work environment for them.
Absolutely.
Great job, guys. I just had a couple questions if I could. And a question I had about the way you've been able to supplement your nonviolent crisis intervention training with our PREPARE training. Now, nonviolent crisis intervention is typically used in a hospital or an educational or juvenile correction setting, and PREPARE training is used more typically in a business or even a retail environment. But you guys have been able to effectively integrate those two.
Absolutely.
Could you explain that a little more for us?
So when we were talking about when we worked through our NCI, and again, we were working through with all of our patient care staff, we were having a lot of our, because again, in a hospital setting, we have a lot of all those other types of people, as you were just identifying. We have our AHR, our building and grounds, our business center staff right on site with us, and oftentimes they're seeing patients or they're seeing some of these incidents occur. And so a lot of them were identifying what do we do, what's expected of us, and it wasn't really appropriate to have them coming through our longer 8-hour program of NCI just because there's a lot of things in there that really didn't pertain to them. And so we started looking for ideas. We were tasked by our aggressive committee to start looking at different options, myself and James. We stumbled kind of upon PTP on NCI's website, looked into it, and kind of found that would be the best option for our staff. And again, because it gets you right up to that point of that person acting out and then getting for that team. And the nice thing we really liked about it is it pairs nicely with NCI where all the terminology is the same, as James was hitting on earlier. The terminology is the same, so when they're calling us, we know what they're trained on, we know what they're talking about, and so that really helped us as well. It was also pivotal for us in rolling this out to all of our hospitals, all of our critical access hospitals, because now we have a shortened version because, again, our smaller hospitals maybe didn't have the budget to roll out this 8-hour NCI right away. And so we started rolling out this PTP with it, and we started getting a lot of their staff, their leadership staff, their business office staff through it, and we realized that we were getting a lot of good outcomes from it as well.
Outstanding.
Yeah, with that, the PREPARE training as well, it is vital. It's congruent, like Paul mentioned, and it gets staff up to, the big concern we had with the NCI program, a lot of leaders weren't sending their staff because they were kind of getting hung up on the physical intervention part of it. Our staff aren't going to be, if something happens, they're not going to be, our lab staff's not going to be in there restraining a patient. If something happens, our HR person walking down the hallway, nutrition's not going to be in there restraining the patient. And that's certainly true and accurate, but all the other, that's a very small part of the program, and that's what we tried to get across to them. And providing this PTP program cut out the physical aspect. It still taught staff what to do in a violent or aggressive incident, taught them to get out of there, stay safe, all those good tools, but it didn't go into them having to go hands-on, which they wouldn't do as part of their job. So it really works well for the different staff we had. And the managers felt a little more empowered to decide, do my staff more need this NCI training, or do they more need PTP? A big advantage we're seeing now at the location I work at with an attached nursing home is staff is identifying certain people they want to go to the full NCI and certain staff to go to the PTP. And we talked about how that will work well because they pair perfectly together. So it gives managers a little more leeway to determine how they want to use their budgets and what staff are best appropriate.
So
to
flexibility.
send. Definitely
Yeah,
flexibility.
Excellent. Another question I had was if you had maybe a hands-on success story de-escalating a person or a situation using CPI techniques.
Sure, I can tell about something that happened. I think in Paul and my role as not only security staff, who are kind of that frontline staff, walking through the building, interacting with staff on a daily basis. When we're not doing that, we're generally teaching the program and we're seeing these same staff members come to our programs. So when something does occur and we show up, sometimes it does feel like there's an extra level of expectation. Oh, the security guys are here that also teach the NCI program. They can obviously fix anything, right? I mean, obviously it's not always the case, but I remember responding to call on our locked mental health unit. There's a behavioral kind of IC within the mental health unit for more challenging patients. And I got called down there to deal with a patient who was in that area, They had their scrub shirt off, and they were at a couple of them, and they were swinging them as a weapon, like hitting the glass on the door, telling any staff that came in they're going to get hit. So thankfully, staff had gone to this program. They stayed in the locked nursing area, didn't go in there, try to deal with this guy until we had a big team there. So we got a big team there, and I remember when we had a brand new staff member show up, just had gone through our training, was there, and I'm like, well, this is probably a good one for them to observe. It could, might not go very well. This person's not backing down. In my mind, before this person got there, I figured, okay, we got to get enough people here, and we're going to run in there and take them down. I mean, there's not much else we can do. They're off their meds. They're not thinking clearly. They're swinging the shirt, trying to whip us with it. And new staff member got there, and I kind of felt the need to, well, we need to show this person how it's done right. This is, we need to spend time talking with this guy. So from the area where we were safe and the patient was safe, again, risky behavior he was doing, but he wasn't hurting himself and he wasn't hurting us at that point. So we had time to intervene, maybe verbally first. We had some time to talk to him, set some good limits with this guy, told him our expectations, spent about 2 or 3 extra minutes talking to this guy than maybe in my mind I thought we would have, primarily because we had this newer staff member there and really wanted to model that good behavior for them. And surprisingly enough, we got the guy to, I told the guy what he needed to do back in his room and sitting on his bed. He needed to stay in there for the next half hour, gave him the limits that the staff had required, opened the door to talk to the guy, and he said he would do it. We set the limit. He walked in his room on his own, sat down in his bed. We didn't have to administer meds. We didn't have to go hands-on restraint. Giving that little bit extra time, setting the limits, giving him time to best respond, even in that very high-level critical state, was a big success. And it's important to note that even in a situation that seems like there's no other option except physical, sometimes there are other choices there too.
That's a good illustrative example. Thank you. Thank you for joining us today on Unrestrained. Tune in again soon for another interview with an expert in behavior management. Until then, this is your host, Terry Vitone, hoping your intention is prevention.